I'm Dr. James Ehrlich. I'm the National Cardiology and Regional Medical Director for CardioDX. I was asked to address some of the issues that GSS are experiencing as far as other cardiovascular tests that primary care physicians are using, and to explain such areas as coronary calcium CT and carotid IMT. To fully appreciate why physicians are using coronary calcium or carotid IMT or other modalities, it's important to realize the difference between asymptomatic risk assessment versus our area of interest, which is patients who have stable symptoms. So physicians generally are looking for evidence of early atherosclerosis for risk assessment in asymptomatics. We are presenting the CHORUS test to explain chest symptoms, and so we're looking for whether there is advanced disease, in other words, significant stenosis. It's important to recognize the legitimate roles of other tests that are very well established, and to make sure you never position the CHORUS test as competitive or to criticize physician testing choices. It's important to understand where the CHORUS test fits into a practice that does other testing, and certainly we have a non-competitive role. It's helpful to understand physician and patient misconceptions about each test and understand the risks involved with each procedure and the proper usage. Now, I present this colorful depiction of the difference between when we are proposing our test. In the upper right corner is an individual with chest symptoms, and what is happening for asymptomatic individuals, starting with a child exposed to various noxious stimuli, risk factors, bad food, poor exercise habits, obesity, and the atherosclerosis timeline, which starts out with early problems with endothelial health, which we'll discuss soon, developing towards atheromas, and ultimately disrupted plaque or events like heart attacks and strokes or significant stenosis. The physician is interested in finding out who's really at risk in a practice. Here is Jim Fix on the left, who most physicians would say was at low risk, and yet died of a heart attack at 53. Sir Winston Churchill broke every rule of the book as far as healthy living, had a lot of risk factors, and died at 91. So physicians are recognizing the challenge of figuring out who's really at risk in their practice, and understanding that conventional risk factors are not very good at differentiating that risk. Let's look at serum cholesterol. Most physicians will order this test, and many are starting to realize that it does not distinguish very well who really is going to have a heart attack and who doesn't. You see this extensive overlap where the majority of people who actually have coronary heart disease in black have the same cholesterol as those who don't develop coronary heart disease. So we're seeing this problem that traditional tests and risk factors do not identify who's at risk, and that's why physicians are reaching for things like coronary calcium imaging and carotid IMT. So what's available to clinicians? Conventional risk factor analysis would look at risk factors like smoking, presence of diabetes, high cholesterol, and family history, which gets you part of the way. Sophisticated lipid analysis, which we'll discuss, will explain risk, but are not powerful predictors of risk. They do give us targets for therapy. Non-invasive testing like stress tests, exercise treadmill test, ankle brachial index are used. These are physiologic tests. And there are others that we'll discuss like endothelial function testing and arterial stiffness. And then there's cardiovascular biomarkers. You're hearing about inflammatory biomarkers like CRP and LPPLA2. There are many others that are in practice. And then non-invasive imaging like coronary calcium quantification, or what we call coronary artery calcium scoring, which is a CT method, and carotid IMT, which is often office-based and is ultrasound. A group of us developed the Association for the Eradication of Heart Attack, and we developed the National SHAPE program, Screening for Heart Attack Prevention and Education. And we were looking for candidate tools for primary care physicians to help identify high-risk people who have atherosclerosis or who have high risk for atherosclerosis and cardiac events. And in this, we're looking at coronary calcium scores, we're looking at carotid IMT, and other tests that we'll talk about, physiologic tests like endothelial function and arterial stiffness, and also various blood tests that you see on the left and some risk factors. Now, it turns out coronary calcium and carotid IMT were chosen by our group as very powerful predictors of events, especially coronary calcium, and they can detect subclinical atherosclerosis. We have to recognize that the detection of atherosclerosis, early disease, predicts events like heart attacks and strokes much better than risk factors. You're already on the way to having the event. It's an intermediary endpoint. Coronary artery calcium is the strongest predictor of events. We'll go through that data. Carotid IMT is a weak predictor of cardiac events, but better than risk factors, and a better predictor of stroke than coronary calcium. Traditional risk factors, as I mentioned, fails to accurately identify the individual at risk. They work well for populations. And cholesterol levels and advanced testing and biomarkers help explain atherosclerosis for physicians, and they provide targets of therapy, but they're not strong predictors. So in the use of tests for asymptomatic patients in primary care, we find that physicians are using these tests primarily for screening for unexpected disease, but also assessment of the health of their vascular tree. Risk stratification is important for prediction of heart events and deciding who should be on therapy, how intense the therapy should be, and how aggressive should risk factor modification be. So if you're in the top quartile of the coronary calcium score, your LDL levels are generally going to be brought down below 70, and you're going to be treated very aggressively. You're also going to get blood tests to find out why you may have so much atherosclerosis. We also use these tests to monitor the progression of atherosclerosis and the effect of our therapies or the effect of certain disease states on the progression and the plaque burden activity. When the patient has extensive atherosclerosis, even if they're asymptomatic, for example, a coronary calcium score greater than 400 is considered severe and confers an elevated risk for a hidden obstruction. We call that hidden ischemia or occult ischemia. And so most of those patients who have such severe disease, even when they're asymptomatic, will be referred to cardiologists for either CT angiography or a nuclear stress test or echo, looking for hidden stenosis. And finally, these tests are often used both to reassure patients who have a family history or who are at high risk, who may actually wind up having a low plaque burden, and also to motivate patients who have elevated scores, an elevated CIMT, for better compliance in risk factor modification. So we can divide the categories of tests that are used in primary care practice for asymptomatic patients into imaging tests. Carotid IMT and coronary calcium CT or calcium scoring were the two that our SHAPE program recommends. You'll see a few physicians using endothelial function tests, so I'll describe that in the presentation, and also arterial stiffness tests. For example, the sphygmocord test that looks at central artery blood pressure, central aortic blood pressure, and vascular compliance. And also, exercise stress tests are used very often in primary care practice, either for an exercise prescription, or some of them are looking for heart disease with these tests. Finally, you'll hear from various physicians about their fancy laboratory tests. Certainly, they're all doing traditional, conventional cholesterol tests, but some of them are using advanced lipoprotein tests that go by the names of the VAP test from Athertech, or tests from Health Diagnostics Lab, Berkeley, Boston Diagnostics, SpectraCell, LipoSciences. And also inflammatory biomarkers are being used increasingly to see if the plaque that one has is actually vulnerable to rupture, and CRP and LPPLA2 are popular choices. And then finally, certain genomics tests are being used, like ApoE, other SNPs, single nucleotide polymorphisms, cytokines like adiponectin, metabolic tests like insulin and hemoglobin A1C, various proteomic tests, fibrinogen, homocysteine are used commonly, aspirin resistance testing, various clotting factors and polymorphisms of clotting factors as risk factors. I didn't mention or put on this slide, but BNP, which is often looked as a risk factor, natriuretic peptides, and myeloperoxidase and troponin you're hearing about, which may be better used in symptomatic patients, but are used for risk prediction in some of these practices. Now it's important to understand the difference between stable and unstable plaque. On the left, we see an example of stable plaque, and the three characteristics would be a small lipid core, a very thick fibrous cap, and very few, if any, inflammatory cells eating away at the shoulders of the plaque. Plaque becomes vulnerable to rupture or unstable, which can cause an acute coronary syndrome or a completed event when there's a thin fibrous cap made thinner by inflammatory cells and a huge lipid-rich core, which when disrupted, when the fibrous cap is disrupted, it exposes platelets running in the blood system to this lipid core and giving rise to a thrombosis or a completed coronary event. So here we see an example of stable plaque, again on the left, with a thick fibrous cap and a small lipid core. And on the right is an unstable plaque that has already disrupted. The fibrous cap is ruptured, leading to the thrombus formation or a clot, and this was an unstable plaque, presumably very inflamed. So the test that you're hearing most about from physicians is the coronary calcium imaging test, coronary artery calcium scoring, using either electron beam tomography, as I used for many years in 4 cities in the United States, and we tested about 50,000 patients. And now more often with the multi-slice CT scanners. These are scanners that patients get on. They get some radiation, not very much, and there are about 35 to 40 images of the heart, and the workstation will quantify the amount of coronary calcium, a recognized, proven marker and a strong predictor for future events. So tomograms are taken, slices of the heart, and here on the right you see one image where the radiologist or cardiologist can examine the coronary arteries and other structures in the chest, and the workstation will quantify in each coronary artery the amount of coronary calcium that's produced. Now this is based on our understanding the fact that fairly early in the process, as the person starts to develop atherosclerosis, there are ruptures of plaque that are going on a microscopic level, and then attempts at healing, which show evidence of calcium, which is a convenient radiologic marker and can be used to help identify atherosclerosis. Now, this is calcified atherosclerosis, but in the next slide, we'll show the relationship between the calcified plaque and the total amount of atherosclerosis burden. But importantly, if somebody has calcified atherosclerosis, they're starting to turn over plaque, they're starting to rupture plaque, and the magnitude of the cardiac calcium score becomes a very strong predictor of future events and identifies those individuals who need aggressive risk factor modification, often including lipid-lowering therapy. This is a concept that is often confused by both physicians and our personnel at CardioDX. We often talk about, well, the cardiac calcium scan only measures the calcified plaque, whereas the CORIS test measures atherosclerosis disease burden from both calcified and uncalcified plaque. Well, it's not that simple. It turns out we understand histopathologically the relationship between the calcified plaque and the typical amount of uncalcified plaque, which may be more vulnerable to rupture. And so it's what it keeps company with statistically. The significance of having cardiac calcium is not that we look for the vulnerable plaque, we look for the vulnerable patient, the patient that has a lot of atherosclerosis. So the more atherosclerosis you have, as measured by the cardiac calcium score, the tip of the iceberg, the atherosclerotic iceberg, the more this person has plaque generally, and the more likely they're going to have problems in the future. Please don't be telling doctors who have invested heavily, both educationally and in their practice, in sending asymptomatic people to get cardiac calcium scores that they're only measuring the calcified plaque. We know that, but most of these doctors also understand the significance of having a high calcified cardiac calcium score. There are many studies, beginning with this one published in the American Heart Association journal Circulation. There are many articles proving that cardiac calcium measurements, either by EBCT or multi-slice CT, have strong predictive value, about 10 times more predictive than traditional risk factors. Here it is here from this study, showing that even moderate levels of cardiac calcium, score of 100 or 160, confer a risk about a magnitude, about 10 times higher than being in the top quartile of any single risk factor. So early disease, moderate disease, that's atherosclerosis, predicts events, especially left untreated. We generate at these centers a cardiac calcium report that not only comments about the total amount of atherosclerosis, at least calcified plaque, and its volume, and gives images of this, but also other clinical findings, maybe lung findings, and recommendations for further testing, and also sometimes recommendations for management. So here is an example of a patient who has severe calcified atherosclerosis, multi-vessel, involving all the vessels. A score greater than 400 is considered severe. And many of these people will actually need cardiologists to determine whether they have ischemic, hidden atherosclerosis, hidden stenosis. And so here it is here. Atherosclerosis, hidden stenosis. And so here it is here. One of the misconceptions is that having blockage is actually worse prognostically for future cardiac events than having just a lot of non-obstructive disease. Well, it's not true in the asymptomatic person. So here, a positive nuclear scan gives a event rate, which is not small, of 7% per year, but a coronary calcium score greater than 1,000, which we sometimes see, is much worse. This is a 25% per year event rates in this study. So these people were dropping like flies if they had a lot of atherosclerosis. So the test really helpful for prognosis and for identifying people who need risk factor modification. When we look at the event rates based on scores, we're trying to find out which individuals who are asymptomatic have similar risk if somebody's already had a heart attack. We call that a CHD equivalent, and that occurs with a score of about 100, as seen by this red line. So you have a score of about 100, or in many centers, if you're in the top quartile for your age and gender, you're going to be treated the same way we treat people who have proven heart disease and get the LDLs low, usually below 70 or at least below 100, and manage risk factors much more aggressively. Scores greater than a 400, we're going to send to cardiologists to look for hidden blockage. An important advantage of visualizing coronary calcium and showing patients what their images look like is that there are studies now showing that looking at a picture of your heart improves your compliance with the recommendations from physicians, whether it's adherence to statin therapy in this study or other recommendations from doctors. Doctors just telling patients you have high cholesterol or that everybody should be on a statin because it should be in the drinking water and it's so great is associated with a high dropout rate. But people who actually see evidence that they're starting to plug up their coronary arteries tend to stay on therapy much longer, and that's been proven. So when we look at cost-effective benefits of coronary calcium, you exclude patients who have a very low score who may not need therapy, even if their cholesterol is high. You select the right patients who have elevated burden for cholesterol-lowering therapy because those drugs stabilize plaque. They convert that unstable plaque to stable plaque. They thicken the fibrous core, they're anti-inflammatory, and they shrink that lipid pool. You can help arrest the progression to advanced disease by identifying people with coronary calcium imaging. And certainly in patients who may present with atypical chest pain, a 0 score has been shown to not be associated with obstructive coronary disease. And we'll talk about why this is still not too competitive with our chorus test, because chorus test, remember, is for stable chest pains, and most patients don't have a 0 score. And also, finally, it's cost effective because we wind up using the most expensive and aggressive therapy for those at the highest risk. So what do we do with a calcium score? Well, if the score is very low, for example, 0 to 10 in a middle-aged individual would be very low, general public health guidelines are recommended. Cessation of smoking, maintenance of adequate diet and exercise, and even if the patient has elevated cholesterol, we often don't treat it with medications. Maybe a non-pharmacologic approach is used. As the score gets higher and higher, we look for an explanation for why the person has atherosclerosis, and we often do advanced lipoprotein testing looking for things like small dense LDL and Lp(a). And we wind up getting more aggressive in our risk factor modification to the point where when the score exceeds those who have heart disease in the past, or a score greater than 100, for example, we might apply secondary guidelines. In other words, get the LDLs down to those people who already had a heart attack, LDL below 100 or 70. We might do further risk stratification with exercise testing. And if the score is greater than 400, we often will refer for nuclear stress tests or echoes looking for occult ischemia. Here is a study that had a combination of asymptomatic people and those with atypical chest pain, so it was a mixed group. But it showed that in the group that had a score greater than 400, a significant number of these people did have blockage, measured by the thallium stress test. Now, typically in studies that look at just purely asymptomatic individuals, no chest pain, about 10 to 15% of those people who have a lot of atherosclerosis, score greater than 400, will also have ischemic heart disease that they may or may not report as symptoms. You may notice a few physicians are actually looking at the health of the vessels, the endothelium, the lining of the vessels, and it's important generally for GSS to understand early atherosclerosis and really the link between risk factors and the development of atherosclerosis begins with an attack on this sensitive lining we call the endothelium, which turns out to be a huge organ or tissue. In a 70-kilo man, there's about 1 trillion endothelial cells. It's the largest organ or tissue in the body. Its surface area is about 6 tennis courts in the average male. And the total weight is equivalent to about 5 hearts or heavier than a liver. Importantly, again, the interaction of various lifestyles, stress, aging, hormones, high cholesterol, blood pressure, with a genetic background that may be adverse, can affect the arterial wall in a negative way, so that the vessels begin to show damage in the endothelium, which sets the stage for the development of atherosclerosis or plaque. And there are tests that can determine the health of these vessels. The standard test that's been used for many years, mostly in research, is not only in a few centers, and is very difficult as far as technique and reproducibility. But it uses brachial artery ultrasound and looking for what we call flow-mediated dilatation or endothelial-dependent vasomotion. Reactive hyperemia is another term. Basically, a blood pressure cuff is placed on the forearm and inflated above systole for 5 minutes and then deflated. That shears nitric oxide from the vessels, and then using a probe on the brachial artery with ultrasound, you can detect increasing size of the brachial artery, and that's a healthy sign, so healthy vasoreactivity or reactive hyperemia. Physicians, a few of them, are using the EndoPAT device from Israel, which allows in the office a very accurate determination of vascular health or endothelial function. Simply, blood pressure again is placed above the elbow. There is a inflated to above systole and then released. The nitric oxide is then released, and there are probes on the digital arteries on the fingers that can help determine the dilatation of those very sensitive digital arteries. And there's an algorithm, and the calculated reactive hyperemia index is reported, and that's a reflection of endothelial health. So again, you see a very robust signal, which is very easy to interpret, and an automatic calculation of this peripheral arterial tonometry reactive hyperemia test. A few physicians are using a technology from Houston, Texas, called the Vendus test, which is looking at endothelial function combined with microvascular reactivity or health and temperature rebound. So again, there's an inflation of a cuff, and instead of looking at the vessels getting larger in the digital arteries, there is a sensitive measurement of temperature in the hand, and it's calculated, and this is called temperature rebound. And here it is here. There is a elevation, healthy response like this after you release the cuff, is to see a big change in temperature in the hand, reflecting reactive hyperemia. A few doctors have this test. It's being heavily advertised on the internet to physicians to buy this. And again, it's generally for asymptomatic individuals. And here is an example from a clinical study. So in green, you see somebody who has neither metabolic syndrome or diabetes. Those people who have metabolic syndrome get a depression of their temperature rebound in yellow. And those with the more significant condition of established diabetes have even poorer microvascular health and in red. So it's a very, very nice test. And it has some prediction of future events. Another use of the endothelial function test, since it's so sensitive, physicians can either show the effect of lifestyle, stress, diet, or exercise on the vessel health, or also the effect of nutraceuticals. So many integrative and naturopathic physicians are actually using this test to demonstrate the beneficial effects of their nutritional program or supplementation. Here is an example of what happens when you go into McDonald's and you have an Egg McMuffin, a sausage McMuffin, 2 hash browns, a Big Mac attack, basically. 6 hours of worsening deterioration of vessel health from one meal. So you can imagine, let's say, an adolescent going to McDonald's twice a day, every day. You can see where bad food affecting vessel health can eventually set the stage for an older adult developing early atherosclerosis. Another relatively popular tool for progressive physicians is the use of carotid IMT and ultrasound technique, which can be a portable technique that the physician owns, or very commonly, technology is brought in by a vascular laboratory service, an ultrasound service, and the physician generally can make quite a good living, either billing insurance or more commonly charging patients for this very quick and safe procedure that does not involve radiation. And so here's a more fancy machine. I was involved with this one, the Cardio Health workstation from Panasonic, which does automated carotid IMT measurements. So in real time, the patient gets their results. And it's very accurate and it's very reproducible. And it uses EKG gating and various ways of auto-capturing images. So either way, these are being used in practice, and there are many other services and workstations for this. Essentially, we're looking at the far wall of the common carotid and measuring the inner two layers, the intima and media. Right here you see it depicted. And the thickening of these layers reflect atherosclerosis and hemodynamic changes and have been shown to be predictive of risk. So again, you get a thickening of the intima and media, which has to be measured by ultrasound, and this is reported and compared with other people of the same age, gender, and ethnicity, and doctors decide whether the person is at high risk for heart attacks and strokes based on this. Especially important is the finding discrete plaque or atheromas, which confers a higher risk. But again, the far wall of the common carotid is looked at, and there are proprietary algorithms and databases that allow one to calculate risk. And there's various ways of doing this, but essentially we're looking at, again, this measurement of the intima and the media, and a score or vascular age is often computed. So if you're 55 years old and your carotid IMT is the same as the average 70-year-old, you'll be reported as having a vascular age of 70, even though your chronologic age is 55. So many physicians are doing this and are very enthusiastic about doing it. And it's not at all competitive, although you're hearing from these doctors that we already do carotid IMT. It's not at all competitive with what we're doing, which is primarily making a decision about future cardiac tests or further cardiac tests in symptomatic patients. A picture is worth 1,000 words, and in the case of carotid imaging and coronary calcium, there's literature that show that patients seeing evidence of worsening vascular health in the case of atheromas or thickened carotid improves compliance with physician recommendations. And importantly, there is literature. This happens to be the first publication showing the prognostic significance of increasing carotid IMT. So when you get to the 5th quintile or the 4th quintile of carotid thickness, IMT thickness, compared to others your age, your event rates go up and your ability to survive goes down. So this is cumulative event-free rates, or Kaplan-Meier survivor curve. And it's a moderate predictor of events, much less than coronary calcium, although it's pretty good for stroke prediction. And here we see it here, Framingham risk factors on the left, IMT confers a risk, and then on the right, if you see discrete plaque, there's going to be elevated risk. Finally, you may see doctors using a technology, the SphygmoCor is one, using applanation tonometry for looking for arterial stiffness, arterial compliance, and central aortic blood pressure. This turns out to be a predictor of risk. It's also much better than sphygmomanometry in understanding the real work the heart is experiencing. So there are studies that show that groups of people who are on blood pressure pills might have the same blood pressure, but those who have the stiffer vessels, as measured by this technique, do worse. So fairly sophisticated practices use this. Sometimes integrative practices are using this again to show the effects of some of their nutraceuticals on stiffness of vessels. It's based on pulse wave velocity, and so the reflected waves from stiff vessels coming back to the tonometer come back faster, and this is measured. And so these people develop waveforms that reflect the stiffness of their vessels, and you can calculate, or the machine calculates, the real blood pressure that the heart is experiencing. We call that central blood pressure. And the extra work that the heart is doing, we call that augmentation index. And you can see here that being in the third tertile, having worse central pulse pressure than others, confers mortality, a higher mortality risk. So this is important. And these, of course, are asymptomatic individuals who may have hypertension, may not, but have elevated central blood pressure. Now I'm going to conclude this presentation by mentioning what you're already experiencing, that many primary care physicians believe they're already doing tests like the chorus test, and it's going to be incumbent upon you to understand the common misconceptions, the real roles of these tests, to reinforce with physicians and educate them about how our test is addressing a different population of people, has a different role, and has a different purpose. And so the chorus, of course, helps determine the need for advanced and further testing or not, and is used in stable chest pain patients. And most of these patients that are getting the other tests are asymptomatic people with risk factors. So one of the statements you may hear commonly is, we already use coronary calcium CT at our practice. Why do we need this test? First of all, any doctor who's using coronary calcium is fairly knowledgeable and sophisticated. I would congratulate that practice as being ahead of the curve, acknowledge the fact that coronary calcium is the most powerful predictor of events in asymptomatic individuals and is great for risk stratification. But the chorus test is for the stable symptomatic patient, and you may need to remind the practice that there's really no literature addressing coronary calcium CT in stable chest symptoms. There are some studies that have been done in ERs with patients with acute coronary syndromes showing that if you happen to have a 0 score, you don't have obstructive disease. But the patient who has an average score for age and has stable chest symptoms, we have no clue based on our literature whether they have stenosis or not. So that's where the chorus test could fit in. You could also mention, if the doctor is using the chorus test in high-risk asymptomatics, that the coronary calcium score requires the patient to be old enough to start to calcify plaque. So it's not very useful in men under the age of, say, 40 to 45, and women less than 50 to 55, and yet the chorus test should reflect atherosclerosis activity and disease burden in any age group. And again, I would never talk to doctors and show any ignorance about hard versus soft plaque and how the chorus test measures all plaque, because as mentioned earlier, it's not that simple. Most of these doctors understand why they're looking for this marker of hard plaque and its relationship to total plaque burden. You may hear this statement, we use carotid IMT in our practice, so we don't need your chorus test. Again, CIMT shows the practice is reasonably sophisticated. It often shows that it's a practice that wants to generate some extra income. It's for the asymptomatic patient. It's often seen in concierge practices and integrative practices. They're looking for vascular age, and it does not compete with the chorus test at all. Finally, you see a few patients or practices that say we do advanced blood testing, and you'll hear about the Singulex testing and the Cleveland Heart Lab and troponin and genomics and advanced lipids, and we don't need this other test. And again, it'll be important for you to mention where the CORIS test fits in with chest symptom patients, whether the patients need to see cardiologists, and maybe the difference, as you were talking about, between gene expression testing and SNPs or genomics. Final slide here. I do want to mention that we could do some future webinars to go into depth of some of the areas that you're already experiencing. We can do this live and interactively, and then for those who cannot make it, we can archive them on a private website or YouTube. And here are some potential topics. We could talk about tests for symptomatic patients that cardiologists are using, including stress tests, the nuclear and echo, angiography, catheterizations, and CT angiography, and where this all fits in and how our test is positioned. We could also talk about, have a webinar on what you really need to know about atherosclerosis. When do stress tests become positive? What are some of the misconceptions about atherosclerosis? Why some people can have extensive atherosclerosis and no stenosis or very little, the so-called Glagov remodeling phenomena. We can talk about frequent objections that you're hearing from primary care physicians and from cardiologists, and interactively discuss this. I think we should have a webinar about radiation. A very important role of the CORIS test is to minimize the overall radiation burden, especially to women. And I don't think we've talked enough about the damaging effects of radiation and the actual dose that's being delivered by some of these tests. Most physicians don't recognize how much radiation is in a thallium or a cardiolite or the like, or fluoroscopy. We could also have a webinar talking and discussing unique approaches to cardiologists, conventional primary care physicians, integrative doctors, longevity doctors, naturopathic practices. And finally, we can update you on new studies that we're doing at CardioDX, often initiated by some of our physicians, and some of the emerging uses of our test. So I want to thank you very much for listening in, and hope to do future webinars.